everyone, and welcome to today's PHO webinar presentation on Community Partnerships for Public Health Emergencies, a spotlight on evacuations. My name's Yasmin Khan, and I'm a physician at Public Health Ontario, and I have the pleasure of moderating today's session. I wish to acknowledge the land that I'm speaking from, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. Please note, just in terms of a disclaimer, that I wish to also acknowledge that the webinar is funded in part by a Canadian Institutes of Health Research project grant. By the end of today and this event, we hope that participants will be able to describe evacuation experiences from the perspectives of an Indigenous primary health care organization and a local public health unit. Identify strategies to develop, strengthen, and sustain partnerships with communities. And lastly, to explain key takeaways related to culturally appropriate and safe evacuations. And it's now my pleasure to welcome our speakers for today's event, Dr. Nicole Blackman, Shernette Clarke, and Julia Creglia. Their full bios will be posted in the chat. And just quickly, before I turn it over to Dr. Blackman, Dr. Blackman is the Chief Operating Officer for the Indigenous Primary Health Care Council. Shernette Clarke is the Emergency Management Program Coordinator at the Simcoe-Muskoka District Health Unit. Julia Creglia is a Program Coordinator with the Integrated Care and Clinical Services Department at the Indigenous Primary Health Care Council. And with that, I'm really looking forward to turning it over to Nicole. Thank you.
Thank you, Yasmin. Good morning or good afternoon, everyone. Thank you for joining, and thank you for the opportunity to come and share with you today from IPHCC's perspective, just to present a little bit of understanding about the evacuation history and structure here in Ontario. So as I'm sure many of you are aware, evacuations of First Nation communities due to environmental issues are unfortunately a common occurrence for First Nation communities across the country. When we look at statistics over a 10-year period, we look at evacuations of First Nation community members from wildfires, and we see that there are just over 97,000 community members that have been evacuated over 10 years, with just under 5,500 of them experiencing long-term evacuations, meaning that they were displaced from their homes for greater than 2 months. And then when we look at flood evacuations over the 10-year period, we see that just under 30,000 First Nation community members were evacuated from their homes, with just under 4,000 evacuated for more than 2 months. When we look at the cause for increased evacuation risk, we look at the role that colonization plays and the historical displacement of First Nation communities. Reserves and communities are often in remote areas, and they have low firefighting priority due to the sparse population as well as the limited infrastructure. First Nation communities are also at risk of repeated displacements due to fires. The remoteness of many communities limits their ability to evacuate during disasters, and that's result from limited road access. So usually they are inaccessible during wildfires. And so one example is a Cree community in Northern Ontario. When they were called to evacuate 5 times in July of 2023, they were forced to do so by boat. And this was because there was a lack of road accessibility. Similarly, in August of 2023, a First Nation community in the Yukon was evacuated due to wildfires by plane, as the community was not accessible by road. Indigenous communities are also at risk of repeated displacement due to flooding. Since 2012, a First Nation community in Northern Ontario calls springtime evacuation season after it has experienced over a dozen years of displacement when the Albany River floods. In 2006, the Kashechewan chief drafted permanent relocation plans, and they were approved by the federal government in 2019. However, the plans have yet to be put into action. So when we look at the unique and increased risks during evacuation, Many Indigenous communities strongly rely on fishing, hunting, and harvesting for their livelihood, and wildfires can make affected areas less habitable for the wildlife on which Indigenous communities rely for food. Furthermore, much of the identity, the cultural practices, and the generational teachings of First Nation, Inuit, and Métis are directly related to their local environment. We see a disruption to education attainment for children and youth, as well as employment and family dynamics. When fires forced residents of Yellowknife to evacuate in August of 2023, some Indigenous peoples were moved to urban areas. And for many, this was the first time that they were away from the rural setting. And it created significant challenges with the displacement. According to the local First Nation chiefs, some elders who spoke neither French nor English encountered difficulties with the evacuations as they were not provided with interpreters or language services. According to the Indigenous community, cooperation and collaboration between the Northwest Territory government and the First Nation government were lacking. I'm going to ask if you could advance to the next slide for me. Thank you. When we look at the structure in which evacuation response takes place in Ontario, there are a number of different partners and players at the table. We look at Emergency Management Ontario, and they are responsible for overseeing the continuing operations of the Provincial Emergency Response Centre, who is the central coordinator. The central coordinator, or PHO, it provides 24/7 continuous monitoring of ongoing emergencies and potential emergencies. They often provide or identify the physical location and the specialized resources and are responsible for overarching coordination. Indigenous Services Canada works with the First Nation that's being evacuated to provide advice and emergency assistance services. And the Ministry of Solicitor General is responsible for administering the Emergency Management and Civil Protection Act. And that's the overarching legislation for emergency management in Ontario. Next slide. So there are three different hosting models that are implemented or utilized. One is the municipality-led, and this is where the municipality signs agreements with the federal government, and they are the ones that will coordinate the logistics. And from there, they'll work with different health organizations to support. The second model is the First Nation led, and this is where another First Nation will agree to host the evacuees, and they will coordinate logistics and provide healthcare, and then they'll also work with other local healthcare providers and organizations to support as needed. And then the third one, which is the one that's most commonly used now, is the third party provider, where Emergency Management Ontario will hire a third party to coordinate, and then they will work with the various health organizations to coordinate care. Next slide. The most common third-party provider that is used is ISN Masqua, and it is Canada's first Indigenous Emergency Operations Centre, and it's located in Sault Ste. Marie. It provides Indigenous communities with 24/7 response to emergency situations, including evacuations. And they work in partnership with community and funding partners to provide an Indigenous-led response to evacuations. Next slide, please. When we look at coordination efforts at the provincial level, there are regular calls that are led by the Emergency Operations Center, and the purpose of the calls are information sharing and planning. And this will include identifying the host community, knowing the number of evacuees that will be coming into the host communities, and any health issues or concerns that may need to be considered, such as long-term care placements, as well as hospitalizations, or any treatments that may be required, such as dialysis. Certain attendees that will participate at the provincial level are the Ministry of Health, Ontario Health, Indigenous Services Canada, public health units, the Indigenous Health Authorities, and ISN Masqua. Next slide. When we look at coordination efforts at the local level, those that are involved will vary, and the approach that they will take with planning efforts will vary as well. But again, they will usually meet regularly for information sharing and planning, and attendees usually are universities, public health, the local public health unit, sometimes the municipality, the regional Ontario Health Team, Ontario Health at Home, Red Cross, and sometimes Indigenous Primary Health Care organizations. Next slide, please. And I'm going to pass it over to Shernette to share on local experiences with evacuations.
Thank you, Dr. Blackman, and good afternoon, everyone. Today, I'll be providing a local public health response perspective to an ongoing evacuation that happened last spring. And so I'll be providing a public health viewpoint on that. So as we normally routinely look at any type of emergency response, we typically ensure that we understand the vulnerability, the risk that that often comes with any type of incident. And so, as we went last spring into this particular event planning, looking at the First Nation evacuation, we were needed to have a full understanding of what are the risks, what are the vulnerabilities that this particular First Nation community could face as they were displaced from their home. And so, as Dr. Blackman has alluded, this was due to seasonal flooding for this particular First Nation community. There were 600 evacuees that were displaced from their homes, relocated to multiple different communities across the province, including here in Simcoe, Muskoka. In the Barrie region particular, we hosted 167 evacuees. These were the most medically vulnerable residents as well as their families. And so as I bring through the public health perspective as one of the participating partners that planned for the preparedness, the response, and often and including in the recovery of this particular event. Thank you. So an incident management model was used to facilitate both preparedness planning as well as response for this event. And given that there were multiple partners that started to plan for this event as the community was anticipated to be displaced, there were multiple partners, including provincial partners, an Indigenous, the Indigenous EOC through ISN Mosqua. There were local health system planning. There was the Ministry of Health, and there was also a local Barrie Health Services planning group that met together to look at the coordinated response to this event, always taking in making sure that the community's needs, the community's response is respected, and ensuring that those are integrated into whatever plan that had come forth. Next slide, please. So here in Simcoe, Muskoka, we wanted to truly understand the decision-making process throughout a First Nation evacuation. This was our first time hosting the displaced community, First Nation community in our local jurisdiction. And so we wanted to understand how is the decision-making taking place. And through consultation and through sitting in on multiple meetings and understanding the process, we were made aware that decision for the First Nation evacuation does reside with the First Nation chief and council. And it was very important for us to know that, because if anytime any offering of any services that is provided, we wanted to ensure that that was an agreed upon particular service, as well as that is exactly what the needs of the community are, and it wasn't just anticipated or just put forward. And so the local planning definitely included ISC, so that's Indigenous Services Canada, or First Nation community itself, the PHO, that assisted with the decision making once a local health system plan was developed to service the needs of the individuals and their families. Next slide, please. So locally, our health system partners definitely worked harmoniously to provide a response that was not only just local, but it was predicated on the needs of the community. And it was vital that there was consistent linking as we linked with the community to truly understand what are their needs. Next slide, please. So for our Simcoe Muskoka area, what happened is there was our health partners that got together. We looked at what kind of services could be offered from both public health as well as the multiple local health system partners, and on-site services that was provided and facilitated. That was done through an ISN Moscow Health Services lead. That individual was a local lead that knew the community, was in dialogue with the community, was in dialogue with ISN Moscow, the EOC, to ensure that any needs from the local community was then represented here. And so once we were able to continue our coordination with the community, understanding their needs, bringing that forward, cannot emphasize the need it is for to have those ongoing coordination calls. And that was unique in terms of understanding the needs of this community. But it doesn't take it's not outside of the norm for public health to continue coordination. One thing that, as a lesson learned, that we learned is to learn to anticipate changes and to know that our plans should be flexible, should be adaptable. And that is something that we definitely learned, whether it is environmental factors, whether it's logistical challenges, ensure that our needs and whatever we were representing and whatever we were putting forward, that met the needs of the community and as well as within our own organizations. Next slide, please. So as with any community, whether it is our northern communities or southern communities, is to understand both needs, disparities, inequities of any type of evacuated community. And so this was represented foremost and to any of our emergency plans as we plan here from public health, as well as that was also brought forward at the local planning table. Understanding what are the impacts of the health of the individuals being displaced, as well as what does being displaced actually mean to those individuals, and ensuring, again, can't reiterate that our home communities may not have similar health services. What are the services that they have? What are the services that they need? So it was ensuring that it was definitely needs based. And then we continue to look at how does care continue once an individual or once a community goes back into their local community with that continuity of care. And so those were some of the areas that we definitely ensure that continued right through for anyone that comes into Simcoe Muskoka region. Next slide, please. So public health was one voice among many. And as you can see from the screen, there was or Ontario health teams were present, or local municipality, or local Indigenous partners were also present, long-term care, as well as the province. So we were one voice among many, and we created a health services plan that was truly a collaborative effort. And that really brought and really syncs to our local community strategy of dealing and planning for emergency response. For public health, we definitely had a lead that was a lead liaison officer that liaised with the Indigenous ISN Mosque was lead, and any health services partner, as well as with the province, getting information and working to ensure that a coordinated response was being done and that the plan was representative. So this was not a one agency plan, it was a multi-agency plan. Next slide, please. So what were some of the services that public health actually provided? We provided environmental public health assessments and inspections. Those were done prior to the First Nations community actually coming into our local area. Once we identified the space that they were going to be occupying, we ensured that both food services, so from a food safety perspective, recreational water services that were being offered at the site, that those were in compliance to ensure that there is no risk of illness or disease being done. We also ensured that or looking at our infectious disease or IPAC components, as well as our dental health services or oral health services were also provided on site. And I'll speak a little bit about the dental health services in a while. Next slide, please. So once the community arrived in our area, we actually employed or is our incident management model, where we activated our EOC to ensure that we were getting the up-to-date situational assessment, and we were coordinating any agency response within our agencies itself. We had an SMDHU liaison officer, as I mentioned before, that was the link to the local community, to link in with our health partners or EOC teleconferences, and to bring that information back and to be that one point person to do that as well. And then we also had some of our operational teams sit in with some of our meetings as well. Next slide, please. Next slide. So what we actually learned from a local public health perspective is the necessity to foster trust and to strengthen our relationships, both with our local partners, but also with those who are coming into our community, and be transparent as much as possible. That and to ensure that there is nothing hidden, and to ensure that the community that is coming in, that their voices are heard and that is not lost at all. The Indigenous Incident Management Framework, it works. Understanding that chain of command and respecting it and understanding it really helps us as a local public health unit to ensure that the services that we were offering, and that although we offered them, that those were actually what was needed by the community. And also build those relationships. So just a minute about the dental services. So next slide briefly. So what we did for dental services is to look locally within our dental service providers or health service providers to ensure that any needs, apart from our assessments, that those could actually happen for that community, as that was a need that was identified, and we offered that. And ensure that there's a continuity of care once that community went back home. We actually did the transfer of all the records back to that local community to ensure that the services, any further services, were being procured for them. Next slide, please. And so what to consider as a local public health services, consider doing some cultural sensitivity training for your staff, understanding that there is not just a one fit model, and that it must be adaptable. Consider all those areas as a local health service is being integrated into, and as public health's voice is among many that is serving both the acute services needs of the actual community. And my last two slides. As we continue to prepare for ongoing evacuations, because we know that they do happen, ensure that your local contact list is definitely updated, and that you do routine electronic communication to maintain your connections. That is a lesson learned that public health definitely took away from the local from a local perspective. Maintain those relationships. Plan early. So that's our last slide. Utilize your incident management model Consider the community's cultures, the values, their beliefs. Stay informed, understand vulnerabilities and needs, build your trust, and be very transparent. And although that a public health service or any services is available, ensure that the community does actually need those and is ready and is in acceptance and in agreement to receive those services. And at this time, I will just turn over to Julia to continue the presentation. Thank you.
Thanks, Shernette. Hi, everyone. I'm Julia. I'll now take you through evacuation experiences from an Indigenous primary healthcare perspective. As Nicole outlined earlier, ISN Maskwah works with Indigenous communities to provide an Indigenous-led response when communities require evacuation. However, there is a gap of Indigenous-led response once communities have been evacuated and have arrived in their host community. Coordination efforts don't always involve Indigenous primary healthcare organizations in the host community. However, this is necessary to ensure a more culturally safe evacuation. Next slide, please. So Indigenous primary healthcare organizations use the First Nations Inuit Health Branch primary healthcare model that you'll see on your screen. It includes primary care, which focuses on the diagnosis and treatment of illness and injury, as well as public health protection and health promotion and disease prevention. Indigenous primary healthcare focuses on wellness across the entire lifespan, where physical, mental, emotional, and spiritual health are interconnected and equally important. Indigenous primary healthcare is rooted in the model of holistic health and well-being and ensures that culture, language, and traditional knowledge are not just included, but are central to care. Culturally appropriate, safe, and Indigenous-led services are required for evacuees in the hosting communities. Just because they leave their communities does not mean that they don't deserve or need the same holistic cultural services they receive when they are at home. Next slide. So when Indigenous primary healthcare organizations of the host community are involved in evacuation planning right from the beginning, it can lead to positive experiences and outcomes. In some cases, IPHCOs were able to coordinate culturally appropriate services such as access to traditional foods, reserving spaces for elders, and access to land-based supports. These responses are vital for health and well-being, especially during the trauma of displacement. Next slide, please. Unfortunately, this isn't the case for all evacuations. We've seen some examples where evacuations have extended the trauma of colonization. In one case, an Indigenous community was told that child protection services needed to be involved to provide childcare support, but no childcare programming, schooling, or other childcare arrangements were offered for children and families. This type of policing response, especially when disconnected from meaningful supports, can feel invasive and re-traumatizing. Next slide. There have also been instances where critical information was not shared with the lead IPHCO or Indigenous Primary Healthcare Organization responding to an evacuation. For example, IPHCOs have received late or inaccurate information about the number of and health needs of evacuees. In one evacuation, a local IPHCO wasn't informed until the middle of the night that 5 evacuees with dialysis needs had arrived in their region. There had been no prior information shared, and this kind of error can have life or death consequences and places a heavy burden on Indigenous-led organizations that are trying to respond in real time. Next slide, please. Another example, during an evacuation, mainstream organizations have set up primary healthcare services in various locations without consulting IPHCOs or Indigenous organizations. In one instance, primary healthcare services were set up in a university cafeteria while students were actively eating. This kind of decision-making reflects a lack of cultural understanding and respect. Healthcare spaces for evacuees need to be safe, calm, and welcoming, not improvised in public spaces without privacy or dignity. Next slide. Finally, in many evacuations, local hunters and harvesters have offered to donate traditional food for evacuees. But these donations have been rejected by mainstream organizations, which undermines both food sovereignty and cultural continuity at a time when those things matter most. Next slide, please. Knowing all this, IPHCC has developed some resources to support culturally inclusive and safer evacuation responses, and I'll be providing a high-level overview of our resources today. Next slide. So on your screen, you'll see the First Nation, Inuit, and Métis Community Engagement Guide for Public Health Agencies and the Indigenous Primary Health Care Evacuation Guide. These resources were co-developed with Emerald Health Consulting Group to support public health with their engagement with First Nation, Inuit, and Métis communities. They were developed using a two-eyed seeing approach with input and guidance from IPHCC's membership, as well as Emerald Health's public health expertise. Next slide. So the first resource is the First Nation, Inuit, and Métis Community Engagement Guide, which was designed to support and guide public health agencies to partner, collaborate, and engage with Indigenous communities in a good way. This is where we recommend everyone begin. In order to engage with Indigenous communities in a meaningful way, you have to start by building and maintaining a relationship. And it's much easier to engage with communities during a time of crisis when there's already an established relationship in place. The guide spotlights wise practices to engagement using examples from our IPHCOs and includes approaches to engagement that are trauma-informed and strengths-based. This guide speaks to the importance of co-creating and planning programs with communities versus planning for community, and includes 5 steps to implementation, which walks you through recommended steps to take when looking to engage with Indigenous communities. It also involves creating a sustainability plan. And you'll see on the screen a QR code, which will take you to a copy of the guide on our website. Next slide, please. So next is our Indigenous Primary Health Care Evacuation Guide, and you'll see a QR code again here. So as we've discussed, there's a gap in engaging Indigenous primary health care in planning and implementation of sector evacuation strategies. So the purpose of this guide is to provide partners involved with the sector evacuation response with resources and guidance for establishing a culturally safe and appropriate emergency management and primary care response process. Evacuations are disruptive for anybody, but for Indigenous communities, emergency evacuations create unique risks and experiences that aren't always visible in mainstream. This guide was specifically designed to address the gaps that exist in understanding the unique needs of Indigenous communities and incorporating Indigenous values, perspectives, and approaches in the response process. Next slide. The guide focuses on what happens to community once they have been evacuated to ensure their stay in the host community does not extend ongoing experiences of trauma and colonization. It highlights the need for cultural safety training for anyone involved in emergency planning and response, and emphasizes that Indigenous primary healthcare organizations must be involved in evacuation response teams and must be engaged early in the process. The guide includes key steps to embed Indigenous primary health care in evacuation response teams by engaging early, transitioning leadership to Indigenous health organizations to support community-led response efforts, and providing support in IPHCO absence areas. Next slide. So for more information on IPHCC, any of our resources, please contact relations@iphcc.ca. And I'll now hand it back over to Yasmin.
Thank you so much, Nicole, Shernette, and Julia for those excellent and really thoughtful and informative presentations. So to our audience, we're now going to open the floor for our Q&A session. And this is your chance to ask questions and hear directly from our speakers. So if you haven't already, please go ahead and submit your questions using the Q&A pod. And maybe while we're waiting for our audience to potentially post some questions, I did have a couple questions of my own I could start with. I think, and I think this could be for all speakers, but I noted in Shernette's presentation, you mentioned the after action review or some reflections that your organization had in relation to in relation to your response, and also reflecting on Julia's comments around the importance of co-creating plans, and I think also related to the learning. So I was just curious, maybe to start with Shernette, if you have any thoughts on that after action review or reflection process after the response, either together or in terms of how you did that with your Indigenous partners, and then also welcome Julia and Nicole's comments on that process as well, and how we can do that together.
Yeah, so thanks, Dr. Khan. In terms of debriefing or lessons learned, there were several different sessions that were actually created. One was done through ISN. We participated in their debriefing sessions to, what went well, what did not go well, how were services received, and so one of the feedback that came out of that process was how we were or local response was definitely geared to their needs, and there was a respect of the culture and respect of the individuals coming in, and nothing was forced, and that we worked through all some of the cultural issues. The feedback was definitely integrated to enhance public health response locally within or the public health unit as well. We actually did an actual session of how do our services look. We actually debriefed to look at that and to ensure that whatever services that we are doing, that they are appropriate. This was our first time, and we also integrated into another session. So there were multiple sessions that we were able to provide that feedback right across with even our local health partners too as well. And that was new for them, for understanding the community as well, and bringing those being so aware and listening with a voice, not just listening with the intent to speak, but listening to the stories and listening to those individuals as they spoke and being respectful of that.
Thank you so much, Shernette. Nicole or Julia, would you like to add anything in terms of including in relation to the guide, which I know speaks to some of those processes?
Yeah, I can just add quickly that I think one of the things that we've done over the past couple of years is have connected with a number of our sites that support the evacuations on a regular basis, just to try and stay informed as to what's happening on the front lines. How are the relationships strengthening? Are we seeing any enhancements, or are we seeing ongoing challenges? And then trying to work with local partners in order to be able to address the challenges or to scale and spread any of the wise practices that we're seeing to better support evacuations from the host community perspective, recognizing that there is a significant amount of attention paid to the planning for the evacuations from an Indigenous-led perspective, and then how do we ensure that those considerations are in place with the host considerations as well.
Thank you. One question from our audience is specific. It's related to what we've been talking about in terms of that after action review process, but it's actually about the if the evacuees themselves had the opportunity to provide feedback on their experiences. So I think this is for you, Shernette, and it sounded like you did sort of get that feedback as you were going along. I don't know if there's anything you specifically wanted to add about, providing the evacuees themselves with the opportunity to provide feedback.
During the time we didn't have them specifically on site to provide that. However, they did provide that back to their chief once they returned home. And so that particular their experience here in Simcoe Muskoka was then brought back to the larger group as they debriefed, and so we were told that because of their response and because of their experiences in our area, that our area became now one of their favorite sites to be able to come back again if they were displaced based on the treatment that was there. So that was the feedback that came from the actual community members themselves through their chief.
Thank you so much. Okay, the next question is a little bit also to the local public health unit experience again, but we'll also welcome Nicole and Julia to add their perspective. So were there any other public health service needs that were identified but that couldn't be provided? And regarding the continuity of services that you spoke to, were there any partnership agreements made between local public health units and communities to continue offering services?
In terms of public health services that were not identified, no, there weren't any additional services that were not identified. Because it was needs-based, what was required or what was the needs of the community, that was what we offered and through our services. So originally, our oral health services were not on the board, but that was identified as a need by the community, and so public health quickly wrap that around into part of the offering as that and to work with the local providers. In terms of any ongoing partnership agreements that was made locally, those are already pre-established relationships that we have with our Ontario Health teams, as well as Ontario Health working together. We work together as a community. And so in terms of partnerships, definitely we look for partnerships where we look to and where there's strengths, noting that we were one voice among many. And so we always do a collaboration effort. So at this time, there were no partnership agreements that were established.
Thanks, Shernette. Nicole or Julia, would you like to add anything, maybe not specific to the Simcoe Muskoka response, but just in terms of your, like, any experience you may have had in relation to after the evacuation itself, any partnership agreements between public health units and communities, and sort of how to, any best practices for that?
I think that's what we're starting to see now is we're starting to see more relationship agreements, discussions between IPHCOs and public health units and other partners supporting evacuations. So hopefully more to come with that. And it is also a resource that we have available for public health agencies as well, is relationship agreements, a template to support those discussions.
Thank you. The next question is, and I may pose it to Nicole and Julia first, to share their perspectives from the Indigenous Primary Health Care Council to inform public health units. So from your perspective, what have we learned from feedback that can be used by health units to take forward in their preparations to help with evacuations?
Just looking to see if Julie wants to.
Yeah, I can chime in. I think I think a good first step would be to bring in the local Indigenous primary healthcare organization and try to transfer leadership to them wherever possible to encourage a community-led response. Yeah, anything else to add, Nicole?
I would say, yeah, definitely. I think one of the biggest things or the first things is when you're looking at the table, if there is not an Indigenous organization, so an IPHCO or in the absence of an IPHCO in that area, then assessing like what Indigenous organizations are within the catchment area that should be at the table, I think is one first assessment. And then, as Julia mentioned, where capacity allows for the IPHCOs and the Indigenous organizations, looking towards taking an Indigenous-led approach. And I think with the guide that we put in, it is full of lessons learned and steps and strategies moving forward from those lessons learned and recommendations. So absolutely recommend looking at not only the evacuation guide, but also the First Nation, Inuit, and Métis engagement guide. One of the very first things that we will say is a strong recommendation for anyone, any organization that is supporting evacuations for First Nation communities is mandated Indigenous cultural safety training. The amount of anti-Indigenous racism and discrimination seen across all partners with the evacuation response is quite frankly unacceptable and something that needs to be addressed from a top-down organizational level.
You. Thank you both. Shernette, would you like to add anything from in terms of your perspective within the public health unit to any of your public health unit colleagues, in terms of what you learned from feedback, anything to add to your key messages that you shared?
The only other thing I would say is don't be afraid to engage with your local partners. Don't be afraid to actively listen. Don't be afraid to reach out to other health units that have had a similar response. The resources that is provided, offered through both Julie and Dr. Blackman is exceptional. Those definitely help to booster or any type of response, for any community, but so much more from our First Nation community, and ensuring that they are celebrated and that they are represented, and it's not just lip service, but you're actually doing that and engaging with them.
Thank you. Thanks so much. Okay, our next question is for Julia. So you mentioned that that the challenges most often cross multiple agencies and mostly are community health services versus community social services, and especially during the response and recovery stages. What would you advise in relation to the future to address these challenges as you identified?
Yeah, so there are a lot of different agencies at play when it comes to evacuations, and they all are coming from different perspectives in different places. I've heard of one example where a community stepped off a plane into into their host area and were greeted by a bunch of security guards, which were hired to assist with the evacuation, but seeing the big security guards as soon as they step off the plane isn't really like a trauma-informed way of approaching the evacuation. So I think it really comes down to, in the planning stages of the evacuation, ensuring that all parties have cultural safety training and are able to provide supports in a culturally safe way. Anything else to add, Nicole?
The only thing I would add is, again, it goes back to who's at the table, who's at the planning table, right? We can look at what health-led or health-specific organizations are at the table. So is there an IPHCO? But what other groups need to be at the table? Is there a friendship center in the area where they are able to participate and bring the lens from the social services supports and so forth? And so it's really just about inclusivity and ensuring that there is a broad representation of Indigenous organizations there to support the First Nation guests that are coming to the host communities.
That's right.
Thank you both. And the next question from our audience. So regarding the advice to hosting organizations to develop relationships early, such as before the evacuation, so sort of in the preparedness phase, and the challenges we encounter in terms of limited time and resources, what would be suggestions for this? How to potentially identify communities that would be more likely to require these services based on previous instances or other ideas to help identify and prioritize relationships to develop.
I think like from one thing that I would say is that when we're looking at flood evacuations, particularly, it's the same communities that are evacuated year after year. So we know who the communities are. And there are consistency in the host communities. So I think there is an opportunity for host communities that usually support evacuations to maintain ongoing relationships or discussions with those First Nation communities that are frequently evacuated due to floods. To fire, I think it's a little more unpredictable, but there is still some a little bit of consistency as to the communities that are evacuated for fire. So I think that we don't need to discuss or to end the conversations once the evacuation has come to an end. There's an opportunity to take lessons learned together and build in a sustainability plan, and so that you're able to react and respond in a more coordinated approach throughout and keep that relationship going through.
Thank you. Julia, Shernette, would you like to add anything on that question?
No, I think well said.
Okay, I'll move on to our next question. So any lessons learned regarding First Nations community members with or without OHIP cards when the host community primary health care clinic was short-staffed and not able to provide health services to evacuees? So this may be sort of more of a specific question, I think, maybe to start with Shernette.
What we actually did was we were able to connect. We identified with the medical director for the community, as well as we were Ontario Health was part of our planning team as well as the ministry. So going ahead of time, there was the potential, there was the opportunities to have individuals that didn't have OHIP cards, the registration, those were completed ahead of time. So where there were individuals didn't have OHIP and they had national health benefits, we were working with the Indigenous Services Canada as well to ensure that no service was denied. I think that's what I wanted to say. We didn't deny service because they didn't have a card. Whatever the opportunity was to work around that to ensure that those are facilitated after and that the community, that's what was done, working with that.
Mm-hmm. Thanks, Shernette. I don't know, Julia or Nicole, if you wanted to add anything in relation to your evacuation guide, if there's anything in relation to health services and insurance.
I would just say the same as Shernette, is that service is not denied because of a card. So.
Okay, thank you. Okay, so our last question that we have time for today before we wrap up. It is sort of taking kind of like that, a little bit of a zoom out approach. So good to potentially end on. But so maybe I'll pose this to Julia and Nicole, just in terms of your perspectives on mental health for those communities who are evacuated potentially every spring flooding season. As you mentioned, it's often the same communities. If you have any reflections on mental health status or indicators, but also any sort of last remarks related to the resilience of the communities to go through evacuations every year, the asset sort of approach. Welcome your reflections on that as we close.
Yeah, I can. Oh, okay, Julia, go ahead. So, I mean, I think we can all agree that with everything that Indigenous peoples have been through, we are a very resilient population. We're very resilient people. I think that when it comes to mental health for evacuations, that as Julia mentioned, that it can be triggering, it can be traumatizing, and that's why it is so important to ensure that there are cultural services available, that there are access to traditional wellness worker practitioners, so elders, healers, access to ceremony, because evidence has shown that access to culture or culture as treatment significantly impacts mental health in a positive way. So that's why I do think it is super important to be working with Indigenous organizations to ensure that there is access to traditional wellness services to serve as a protectant factor for the guests that are coming to the host communities.
Thank you so much. Thank you so much. Okay, and so with that, as we conclude today's webinar, I'd like to really sincerely thank Dr. Blackman, Shernette Clarke, and Julia Creglia for today's session, which was really educational and engaging, and I really learned a lot, and I'm sure our audience did as well. Sincere thank you to our audience who joined us today. Your time and active participation are really appreciated. In terms of next steps, our audience will also receive a brief anonymous survey following today's session. We encourage you to take a few minutes to complete it, as your feedback is invaluable to help us strengthen and shape future programming. So thank you all once again, and wishing you a wonderful rest of the day.